All right, everyone, welcome. Today we're going to tackle a really big one of the toughest situations we face in obstetric anesthesiology. We're talking about managing C-sections for mothers with placenta previa and the whole accreta spectrum.
Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Willkommen auf dem Kanal für Anesthesia und Perioperative Medicina. Gracias por acompañarnos hoy en el canal de Anesthesia y Medicina Perioperatoria. आज Anesthesia और Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद. All right, so here's how we're going to break this down. Think of it as building a case, piece by piece. First, we'll set the scene and talk about why this is such a high-stakes challenge. Then, we'll get right into the weeds, defining exactly what Previa and Accreta are. After that, we'll look at our options, our anesthetic toolkit, regional versus general. We'll even explore a pretty incredible innovation, a prophylactic aortic balloon. Then, things get interesting with a case study that throws a real curveball. And finally, we'll tie it all together, talking about why a great team is absolutely non-negotiable here.
So let's start with the big picture, the reality we're all seeing. C-section rates are going up worldwide, and that's not without consequences. We're seeing a direct parallel rise in cases of placenta previa and accreta. This isn't just a chart in a journal. These are the patients walking into our ORs. For us, managing a massive obstetric hemorrhage isn't some niche skill anymore. It's become a core part of what we do to keep moms safe. It's a fundamental.
Okay, before we can even think about managing these cases, we have to know exactly what we're dealing with, right? Down to the pathophysiology. So let's really break down the clinical threat here. We'll start with the basics, the definitions, but this is more than just memorizing terms. It's about getting to the why. Why do these patients bleed so much? First up, placenta previa. So what is it? It's when the placenta implants way too low, down in the lower uterine segment. And the real problem here is all about physiology. Think about it. The lower part of the uterus just doesn't have the same muscle power as the top, the fundus. So after delivery, it can't clamp down effectively. And that failure to contract, well, that's what causes the massive hemorrhage. It's a simple plumbing problem in a way, but because it's about muscle tone, it's a nightmare to control. Okay, now let's layer on the placenta accreta spectrum, or PAS. This is a whole different beast. It's not about where the placenta is, it's about how deep it goes. With PAS, that nice, clean separation layer between the placenta and the uterine muscle, it's just not there. So you have accreta, where the villi are just stuck on the myometrium. Then there's increta, where they've invaded into the muscle, and the worst case scenario, percreta, where they've gone all the way through the uterine wall and can even latch onto the bladder or other organs. And let me be perfectly clear about this. Trying to manually remove the placenta in these cases isn't a separation. It's a traumatic avulsion. You are literally tearing the uterus apart, and that's how you get a catastrophic, uncontrollable hemorrhage. So what are the red flags we should be looking for? What should make our spidey senses tingle? Well, here are the key risk factors. And the number one, the absolute biggest one, is a prior C-section. That scar tissue is the perfect, weak spot for abnormal implantation. Of course, we also look at things like advanced maternal age or any other uterine surgery like a myomectomy. But the one that should really set off alarm bells is what's called pernicious placenta previa. That's when you have an anterior placenta sitting right on top of an old C-section scar. If you see that on the pre-op ultrasound report, you need to start planning for a massive hemorrhage, like yesterday. Okay, so we've defined the enemy. Now let's talk about our weapons, our anesthetic toolkit. This really gets to the heart of our role. For a stable patient, elective C-section, grade 4 previa, what's the better call, regional or general? This has been debated for years, but thankfully we've got some really solid evidence now that points us in a clear direction. So let's just do a quick refresh on the basics. With regional, you've got an awake patient, which is great, and fantastic post-op pain control. The big downside, of course, is the hypotension from the sympathectomy. Then there's general. Patients asleep, you've got a secure airway. For a long time, this was the go-to for these cases, mostly out of fear. The thinking was, what if she starts bleeding massively and her pressure tanks from the spinal? But GA brings its own massive problem to the table. Our volatile agents cause uterine relaxation, which can make atonic bleeding so much worse. It's a real catch-22, a clinical dilemma that, thankfully, we're starting to get some answers on. And this quote right here from the Hong et al. Study really nails the shift in thinking. The old dogma, previa equals GA, was starting to crumble. People were asking, hey, can we actually do this with regional in a stable patient? But an assertion is one thing, data is another. And that's exactly what this trial was designed to find out. Okay, now let's look at the actual data, because this is where it gets really compelling. This graph shows the intraoperative blood pressures. See the lines with the squares?
That's the epidural group. Yeah, you get that initial dip, we expect that, we treat that. But after that, it's remarkably stable, a nice smooth ride. Now, look at the circles. That's the general anesthesia group. It's a total roller coaster. You get a huge hypertensive spike at intubation, and then another one at extubation. In a patient who is a ticking time bomb for hemorrhage, this kind of hemodynamic swing is the last thing you want. The epidural group was just so much more controlled.
And this table, wow, this really shows you the downstream effects. Let's walk through it. First, look at estimated blood loss. You might glance at that and think, they're pretty similar, not statistically significant. But hold on, that is not the whole story. Look at the next line, post-op transfusion. The GA group needed almost 3 times more blood, and that difference was statistically significant. Then my favorite part, time to first analgesic. About 3 hours for the GA group, for the epidural group, almost 12 hours. That's the power of neuraxial opioids, right there. And importantly, the APGAR scores show that the babies did great in both groups, so no downside for the neonate.
So why did the GA group need more blood if the EBL was supposedly similar? This chart tells the story. Look at the hematocrit at the end of surgery. The black bar is the GA group, the white bar is epidural. It's plain as day. The GA patients ended the surgery with a significantly lower hematocrit. This is the proof. It confirms that even if the surgeons estimated similar blood loss, the actual physiologic hit, the real-world blood loss, was worse under general anesthesia, and that's why they needed more transfusions. So what's the bottom line here? It's pretty simple, really. This data is clear. For your stable, elective Previa patient, an epidural isn't just an option, it's the better option. You get more stable hemodynamics, you use less blood product, and your patient gets amazing pain relief for hours afterwards. And the baby does just as well. Honestly, this kind of evidence should make us rethink our old habits. For the right patient, regional should be our default, not the exception. Okay, we've made a strong case for regional and stable Previas, but what about the really scary ones? The suspected accretas, where you know the potential for hemorrhage is just off the charts. For those cases, just reacting isn't good enough. We have to get ahead of the problem. And that's where we're going next. We're going to talk about a technique that's a real game changer. Prophylactic intraoperative abdominal aortic balloon occlusion. It's a mouthful, so we'll just call it IAABO.
And to really get why something like IAABO is even on the table, you have to appreciate the scale of what we're talking about. Look, in a routine C-section, maybe you lose a liter of blood. Okay, manageable. But with a bad accreta, we're talking 3, 4, 5,000 milliliters of blood loss, or more. That's literally the patient's entire circulating blood volume. When the stakes are that high, you can't just play defense. You need a proactive, aggressive game plan.
So how does this IAABO thing actually work? Well, it's a really slick, team-based approach. It starts before the patient even gets to the OR. Interventional radiology comes in, and using the femoral artery, they thread a balloon catheter up into the abdominal aorta. They park it right below the renal arteries. Then, in the OR, when the surgeons are ready to make the uterine incision, they give us the signal. We inflate the balloon. And just like that, you've turned off the fire hose. Blood flow to the pelvis is dramatically reduced, giving the surgeons a much cleaner field to work in. Once they've got hemostasis, we deflate the balloon and blood flow is restored. It's like having a temporary tourniquet on the aorta.
And the results? Honestly, they're nothing short of incredible. Just look at this table comparing cases with and without IABO. Average blood loss? It goes from well over 1.5 liters down to a median of 500 milliliters. That's huge. But the number that really blows me away is the hysterectomy rate. Historically, with these bad accretas, you were looking at a 50, sometimes even 100% chance the patient would lose her uterus. With IABO, that drops to 7%. Think about that. We're not just saving lives, we're preserving their ability to have more children. And the most important number on here, 0 maternal deaths in the IABO group. It's a true game changer.
So here's a great question. If you have this amazing tool like IABO that controls the bleeding, does your choice of anesthesia even matter anymore? Well, this data from Lai and colleagues says you bet it does. They looked at patients who all got IABO and compared neuraxial versus general. And guess what? The neuraxial group still did better. Less blood loss, fewer transfusions, look at that, a median of 0 units transfused, and even shorter surgeries, all statistically significant. The takeaway here is that your anesthesia choice isn't just a footnote. Even with these advanced interventions, a well-managed regional anesthesia continues to deliver better outcomes.
All right, so up to this point, we have been laser-focused on one enemy, hemorrhage. It's the big, obvious threat, right? We've talked about how to pick our anesthetic, how to proactively stop the bleeding, but you know how it is in our line of work. Sometimes it's the threat you don't see coming that's the most dangerous. So now we're going to shift gears and look at a case study, a real twist in the story that introduces a hidden and just as deadly adversary. So let's follow this patient's journey. She's 36, grade I previa, needs an emergency C-section. The team is on it. They know the hemorrhage risk, so they do everything right. Uterine artery ligation, B-Lynch, the whole 9 yards. And it works. The surgery goes well from a bleeding standpoint. But then, post-op day 1, everything goes sideways. She suddenly gets chest pain, her pressure drops to 80 systolic. Now, what's your first thought? Rebleed, right? Especially when you see her H&H has cratered. But the team was sharp. The ECG was weird but nonspecific, and crucially, her D-dimer was high. They looked beyond the obvious, they broadened their differential, and they nailed the diagnosis, acute PE. And thank goodness they did, because with the right treatment, she recovered fully.
So what do we take away from this? It really comes down to this incredible paradox of pregnancy. Nature has made these patients hypercoagulable for a very good reason, to stop them from bleeding to death after delivery. The team was 100% right to focus on hemorrhage. They fought the expected battle and won. But that same life-saving adaptation, that hypercoagulability, becomes a huge risk factor for clots. This case is just such a stark reminder that we can't get tunnel vision. When your patient isn't doing well and it doesn't quite fit the picture you were expecting, you have to take a step back and think, what else could this be? So let's bring all of this home. We've gone through the basic science, we've compared our anesthetic techniques, we've looked at cutting-edge technology, and we've even walked through a terrifying complication. And if you look back at everything we've covered, there is one single thread that connects it all, and that is the absolute, non-negotiable need for a great, well-oiled, multidisciplinary team.
And this is what that team looks like. These are the pillars. You've got OB, of course, doing the surgery. You've got us, anesthesia, running the resuscitation and keeping the patient stable. You have interventional radiology, who are our partners for things like IAABO. You've got neonatology standing by, ready for a baby who might be in trouble. And you have the blood bank, maybe the most important player of all, ready to unleash the massive transfusion protocol. But here's the key. A list of names on a chart isn't a team. A real team is built in the pre-op huddles, where everyone is on the same page. It's built in the middle of the crisis, communicating clearly, and it's built in the debriefs afterwards. It's about moving and thinking as one single unit.
So I want to leave you with this final thought. We spent all this time talking about the expected enemy, hemorrhage, and we learned from our case study to always be looking for the hidden enemy, thromboembolism. So the question I have for all of us is this. What's the next unseen threat? What's the complication that's lurking just around the corner that we haven't even thought about yet? Because having that kind of forward-looking vigilance, that's what's going to keep our patients safe. That's what will define the next level of care for these moms. Thank you so much for joining me for this explainer.